Good afternoon or good evening, ladies and gentlemen. That depends on wherever in the world you are at the moment. But welcome to this seminar that we are presenting. And this webinar has been kindly supported by an unrestricted educational grant from Bizarre's Healthcare. They had no role in the selection of topics or speakers and has not vetted or reviewed the content of the speakers' presentations. Our topic today is cancer and bone health, an ever important and increasingly important topic in the world today. Our first speaker is Professor Peter Ebeling, who is going to address us on the topic of preventing bone loss in women post-chemotherapy. Is menopausal hormone therapy enough? A short introduction of Peter. Peter is the head of Department of Medicine and the head of the School of Clinical Sciences at Monash Health Faculty in Melbourne. So Peter is also a fellow of the Australian Academy of Health and Medical Sciences. He was also elected a fellow of the Royal College of Physicians, London. He was inaugural director of the Australian Institute of Musculoskeletal Science. In 2015, he was made an officer of the General Division of the Order of Australia for Distinguished Services in the field of bone health. Research interest includes musculoskeletal health and disease, public health aspects of vitamin D, post-transplantation osteoporosis and osteoporosis in men. But also very important, Peter has been a long-time friend and supporter of the International Menopause Society, and he always says yes if we ask him to present something. So Peter, this is an extremely interesting topic, and I can't wait to hear what you're going to say.
Well, thank you so much for that very kind introduction, Toby. So I'm just going to try and share my screen, and let me know if you can see the slides okay. Good. Well, I've been charged with talking about preventing bone loss after chemotherapy, and is hormone replacement therapy enough? And these are my disclosures. What I'm going to talk about today are the effects of chemotherapy on bone, and discuss some of the drugs that are used to treat cancer and their direct versus indirect effects on bone, using data from animal models and also human studies where the data are available. But you'll find out that there aren't a lot of human data on some of the drugs that were used to treat cancer today. And then how do we prevent bone loss after chemotherapy? We could try calcium and vitamin D, exercise, menopausal hormone therapy, and anti-resorptive drugs. And I'll just discuss some of the recent international guidelines to help us decide which medications to use and in which patients they're applicable. So what we find with rates of bone loss with cancer therapies is that these are much more rapid than, say, early postmenopausal bone loss. As you can see, in the early menopause, the rate of bone loss is about 2% around perimenopause and early menopause. And it's higher with aromatase inhibitor therapy because the estrogen levels are lower than following natural menopause. And with bone marrow transplantation, androgen deprivation therapy for men with prostate cancer, aromatase inhibitor therapy plus GnRH therapy, and ovarian failure secondary to chemotherapy, there are very high rates of bone loss. And you can see the lumbar spine bone loss at 12 months with ovarian failure secondary to chemotherapy is very high at 7.7%. So I think we need to think about being preemptive in some of these cases. Now I'm going to be talking about the effects of these medications on bone cells. So I thought I'd refresh your memory about the bone remodeling unit. And there are two types of cells that mainly work in renewing our bones every 3 months or so. And what we see are the hematopoietic stem cells from the monocyte lineage differentiate into osteoclasts. They resorb old bone, and then osteoblasts, which come from mesenchymal stem cells, will then move on to the bone surface and create new bone. The other cells that are really important in signaling are the osteocytes. And these are sort of doomed osteoblasts that then go into the bone, and they've got an extensive canalicular network and also secrete important factors like sclerostin that can control bone formation. So this is what I'll be talking about, some of these bone cells today. And what we find in pathological states such as osteoporosis and cancer, with estrogen deficiency, there's an increase in cytokine release, as there is with chemotherapy. And what this does is activate osteoclasts through the rank ligand and rank system, and you get an imbalance with an increase in bone resorption over bone formation. And this means that the resorption pits or cavities that have been formed aren't completely refilled, and you get intrabecular bone, you can get thinning of the trabeculae, but also perforation through these sites of incompletely filled bone resorption, and that can lead to fractures. So it's this imbalance caused by an increase in cytokines, a reduction in sex hormones that increases bone resorption and causes osteoporosis and fractures in cancer. Now, this is a summary of an effect of all the anti-cancer drugs on bone. I don't want you to remember this, but I think it's a useful pyramid. And it's from a paper that Toby and I were involved with that was recently published. Now, what you can see in the bottom row, if you like, are the effect of these drugs on bone cells. And what we really need to concentrate are all the medications that are listed in red, because they're the ones that have adverse effects on these bone cells. So you can see on the left, there's corticosteroids and a TKI called vandatinib, which can reduce bone formation. But we see most of the effect on the bone cells is actually increasing bone resorption with corticosteroids, VEGF inhibitors, aromatase inhibitors, LHRH agonists, and antagonists. So these will all favor increasing bone resorption with also an effect on reducing bone formation. And this will, of course, cause bone loss and an increased fracture risk in the top part of the pyramid with corticosteroids, LHRH agonists and antagonists, aromatase inhibitors, and antiandrogens. So what are the effects of anti-cancer drugs on bone? I'm going to discuss chemotherapy, glucocorticoids, hormone therapy, and specific drugs such as tyrosine kinase inhibitors and other medications. So we looked at the direct effects of chemotherapy on bone in a mouse model where the mice were given a single dose of cytotoxic therapy, and this increased osteoclastogenesis with inadequate osteoblastic bone mineralization. And it did this by increasing inflammatory cytokines. But when we gave a single dose of zoledronic acid prior to cytotoxic therapy, the bone loss was completely inhibited. And then we looked at women and men early after a stem cell transplant and a bone marrow stem cell transplant. And the same inflammatory cytokines were elevated. And in particular, the serum levels of one of these, MCP1, was positively correlated with bone loss at 100 days following allogeneic bone marrow transplantation. And I just thought I'd show you the animal data and some of the human data. So you can see diagrammatically, the closed dark line is the effects of the chemotherapy on the bone volume, trabecular number, trabecular separation, and trabecular thickness. And you can see the bone volume decreasing after the chemotherapy is given. In the dotted black line is where the mice were given zoledronic acid prior to chemotherapy, and this prevented the bone loss. And the dotted line is the control group. And the images of the bone are shown below. So another way to look at this is the effect on trabecular bone volume in the group of animals. And you can see that with the 5FU, the trabecular bone volume went down, but this was prevented by giving zoledronic acid prior to the chemotherapy. And the same was true for trabecular number, trabecular separation, and not much of an effect on trabecular thickness. And then these are the effects on those cytokines I mentioned. And we can see that they're all increasing. And then in the human data below, we can see that the same inflammatory cytokines are also increased in humans. So we thought this was a good model to look what was happening after bone marrow transplantation. And the evidence was that zoledronic acid prevented this chemotherapy-related bone loss. Now, what about glucocorticoids? They have direct effects on bone cells, and they're shown in this diagram here. Now, the main effect is really to reduce osteoblast function and numbers. And so we get this reduction in bone formation, which is greater than the transient increase in osteoclast activity we see with glucocorticoids. Now, what do we use to treat glucocorticoid-induced osteoporosis? We can use aminobisphosphonate, and they really inhibit osteoclast activity. Or it'd be more physiological, really, to give teriparatide, because that would stimulate osteoblast precursors, osteoclast differentiation, and osteoblast function, which is the main defect in glucocorticoid-induced osteoporosis. But nevertheless, both anti-resorptives and teriparatide are effective in this condition. And we know that teriparatide is actually more effective than alendronate in reducing vertebral fractures in postmenopausal women with glucocorticoid-induced osteoporosis. And these are the mechanisms, really. We're talking about bone marrow transplantation, but it's really just an effect of glucocorticoids of high doses. There are direct effects to reduce osteoblast function, but there are also indirect effects on sex steroids. And this is really happening at the hypothalamic pituitary axis, where there's a reduction in gonadotrophins and then a reduction in gonadal function. There are also direct effects on the gut with reduced calcium absorption and also in the kidney with a reduced reabsorption of calcium. And there's an effect on reducing 1-alpha hydroxylation and elevating PTH. So you can get this reduction in bone formation and an increase in bone resorption, which is called uncoupling. And this causes rapid cancellous bone loss in particular. And we all know that vertebral fractures are really common in this condition. So what about hormone therapy? Now, hormone therapy really acts indirectly on bone cells, and these are well known to you. And the ones that we use are GnRH agonists and antagonists, and estrogen inhibitors or SERMs, and also aromatase inhibitors. Aromatase inhibitors really reduce estrogen levels to very low levels, and they will increase bone resorption. And the same is true of the GnRH agonists and antagonists. So this is an indirect effect on the bone cells to increase bone resorption. So the pathways to bone loss in breast cancer are cytotoxic therapy, which the chemotherapy will increase inflammatory markers, but also result in gonadal steroid deficiency, as will GnRH agonists and aromatase inhibitors. And surgery or radiation therapy will also reduce sex steroids, and we get this gonadal steroid deficiency, which is promoting bone resorption. Now, what about fractures with aromatase inhibitors in breast cancer? This is well known from these studies. And we can see the comparison between aromatase inhibitors here and tamoxifen. And you can see that the rates of fractures are higher in the groups treated with aromatase inhibitor rather than tamoxifen. For instance, in the ATAC study, 11% fracture rate with aromatase inhibitors and 7.7% with tamoxifen. And And you can see the other similar changes which were significant. And these are just the changes in bone density after starting aromatase inhibitor therapies. And we can see that with an anastrozole, the rate is about 4%. And this compares with tamoxifen, where there's a slight increase in bone density. And the same is true for the other medications shown on the right. But I think what I wanted to emphasize is if we look at the fracture rates on and off treatment with aromatase inhibitors, the fracture rates really start as soon as patients start on their aromatase inhibitor therapy. So it is a very rapid increase in fracture risk as soon as a patient starts on aromatase inhibitor therapy. So I think we really need to be preemptive here and think about initiating anti-resorptive therapy in those at risk at that time. Now, the other thing is that there's a rapid offset of fracture risk as soon as patients stop treatment. So we don't necessarily need to continue the anti-resorptive therapy if a patient stopped their aromatase inhibitor therapy after 5 or 10 years. It could be a limited course of anti-resorptive therapy, and that has implications on the medication we're choosing. We may not want to choose denosumab, even though it's effective, if we're thinking about stopping it after 5 or 10 years, because we can't just stop it. We'll need to transition to another anti-resorptive drug, and preferably zoledronic acid. And we're not quite sure how to do that optimally at the moment. So just to summarize the effects of aromatase inhibitors, there's near complete estrogen suppression on bone, and they're opposite to the effects of tamoxifen, which is a partial estrogen agonist. And the effect to increase fracture risk is small but clinically significant. And the severity of bone loss will increase as long as the patient is on aromatase inhibitor therapy. But we really need to balance the fracture data against the overall efficacy and tolerability benefits of aromatase inhibitors. And obviously they have an excellent survival benefit. But nevertheless, patients at high risk of osteoporosis should be identified, treated, and monitored. And anti-resorptives prevent bone loss and reduce fractures. And of course, menopausal hormone therapy would be contraindicated in the setting of prior breast cancer in most cases. Now, what about the other anti-cancer drugs? And I'm just going to summarize the evidence for these medications in a few slides. Proteasome inhibitors is one class of drugs. These increase osteoblast activity and inhibit osteoclastogenesis. And we can see increases in bone density at axial sites with one of them, bortezomib. And there's an increase in bone volume with ixazomib, another one, but there are no fracture data. The tyrosine kinase inhibitors are used for certain cancers, but there are no human data on either bone density or fragility fractures, but they can have bone effects, and they can cause periosteal reactions, osteonecrosis, and secondary hyperparathyroidism. So they can affect bone, but not, we don't know if they reduce bone density per se. Now, the immune checkpoint inhibitors are being increasingly used as immunotherapy. And one study with one of these drugs showed a 20% increase in fracture incidence. And we know that immune activation increases osteoclastogenesis and osteoclast activity. So it may be through an increase in bone resorption and decreases in bone density have also been seen with these medications. Now, this is complicated, but some of these medications can be integrated into either osteoblast or osteoclast signaling. And this is a comprehensive review from our paper looking at the various parts of osteoblast function that can be affected by all of the different tyrosine kinase inhibitors. And these can act at different parts of the osteoblast life cycle. They can affect proliferation, early differentiation, or late differentiation when mineralization has been caused. And this is just showing how intimately some of these medications can fit into either osteoblast or osteoclast pathways, I'm not showing the osteoclast pathway because it's quite similar that the different stages of osteoclast activity can all be affected by tyrosine kinase inhibitors. Now, the other anti-cancer drugs to finish then are mTOR inhibitors, which decrease osteoblast and osteoclast activity, and bone marrow edema associated with fractures has been reported after 6 months with everolimus, one of these mTOR inhibitors, but there are no human data on either bone density or fragility fractures. Now, these anti-angiogenic drugs, anti-VEGF antibodies, there are no data on either bone density or fragility fractures, but these drugs can cause osteonecrosis of the jaw. And this occurs without any other associated risk factors due to the anti-angiogenic nature. And that's why we've changed the terminology of bisphosphonate-associated osteonecrosis of the jaw to medication-associated osteonecrosis of the jaw. Now, thalidomide and its derivatives are also anti-angiogenic, and they have direct and indirect inhibitory effects on osteoclasts and an inhibitory effect on osteoblast differentiation. But again, there are no human data on bone density or fragility fractures. So for a lot of these newer medications, there's a lack of evidence about adverse effects on bone density or fractures. So what can we do to prevent the bone loss associated with chemotherapy? It's really important to focus on vitamin D adequacy. We know that vitamin D deficiency is common, and that can result in skeletal effects, including low bone density and fragility fractures. So we really need to correct vitamin D deficiency. The other thing is to ensure an adequate dietary calcium intake. We'd probably recommend 1,000 to 1,300 milligrams a day, depending on your age, from dietary sources. If you use calcium supplements in your patients who can't tolerate dietary calcium, there's no evidence for adverse cardiovascular events if the daily calcium dose is 700 milligrams or less. So you can be reassured, and you can reassure your patients about that. But it's really important to ensure an adequate calcium content of the diet. Now, what about high intensity resistance and impact training? This is a study from Australia, the Liftmore study, and we know that 8 months of this exercise, which is only 30 minutes twice a week, increased lumbar spine and femoral neck bone density and also improved physical function. And femoral neck cortical thickness was improved by 7.3 millimeters and height by 0.4 centimeters. So this is something that we probably recommend to all older people, but also in this setting of post-chemotherapy, we'd recommend that as well to help maintain bone density. But most of the evidence really comes from the use of anti-resorptive drugs. And these are some new guidelines that Toby and I have been involved with and are in press at the moment. And these are the updated IOF guideline for aromatase inhibitor-associated bone loss in postmenopausal women with hormone-sensitive breast cancer. So if a patient with breast cancer is receiving chronic endocrine treatment known to accelerate bone loss, if their T-score is less than -2 and no additional risk factors, we'd recommend exercise, calcium and vitamin D, and either denosumab or bisphosphonate therapy, and often we'll use intravenous bisphosphonates, and monitor bone density every 2 years or check compliance with oral therapy a little bit earlier. And if patients have 2 clinical risk factors, and that could be age greater than 65, a T-score less than -1.5, smoking or a low BMI, or a family history of hip fracture, a personal history of fragility fracture above the age of 50, or oral glucocorticoid use for more than 6 months, we'd also recommend that they go on to anti-resorptive therapy. Now, how do our guidelines compare with other guidelines? The ASCO clinical practice guidelines recommend a T-score cutoff that's lower, -2.5 or less, or a FRAX score of 20% for major osteoporotic fractures, or 3% for hip fractures based on the US adapted FRAX tool. And the doses are as indicated for osteoporosis. and one could use alendronate, residuronate, abandonate, zoledronic acid, or denosumab. With the ESMO clinical practice guidelines, these were slightly different, and postmenopausal women receiving AI therapy for greater than 6 months with a BMD T-score of less than -2 or with 2 or more clinical risk factors, they recommended denosumab as first-line therapy. And you could also use alendronate, residuronate, abandonate, or zoledronic acid. And that was for the duration of the aromatase inhibitor therapy, which at that time was up to 5 years, but as we know, it's often used for up to 10 years now. But I think there are problems in using denosumab that we have to be aware of, and that's when you want to stop the denosumab. So I hope I haven't gone over time, but I'd like to conclude by saying that the rates of bone loss and fractures are increased after chemotherapy for cancer, and this can be caused by glucocorticoids, hormone therapy, and chemotherapy, including cytotoxic drugs, immune checkpoint inhibitors, and mTOR inhibitors. We need to aim for an adequate calcium intake of 1,000 to 1,300 milligrams a day from dietary sources. Vitamin D deficiency is still a global problem that needs to be addressed, and we need to assess individual risk with diet, sun exposure, and high risk groups, and treat those people with 1,000 to 2,000 units a day of vitamin D3. High intensity resistance training will be helpful in increasing bone density. Menopausal hormone therapy is often contraindicated and may not be a potent enough anti-resorptive to use in this setting. And really what we're left with is using anti-resorptive drugs, first-line drugs for those with T-scores of less than -2 or less than -1.5 with 2 clinical risk factors, including the low bone density. So I'd just like to thank you very much for listening. This is where I work at Monash University in Melbourne, and my research team. And I've really enjoyed speaking with you today, and I'll be available to answer questions at the end of the session. So thank you.
So thank you, Peter, for a very interesting and thorough presentation. I personally thoroughly enjoyed it, and I'm looking forward to you answering questions at the end of the next session. So our next talk is a pre-recorded presentation of Professor Mathis Grossmann, another person hailing from Melbourne, Australia. He is a physician scientist trained in both basic biology and in clinical endocrinology. He's professor of medicine at the Department of Medicine, University of Melbourne, Australia, and head of andrology and endocrine breast cancer at Austin Health, a tertiary academic center. He obtained a PhD at the Walter and Eliza Hall Institute in Melbourne. His research focuses on the roles of reproductive hormones in health and disease. His group conducts observational and interventional trials in men with 1 low testosterone and chronic disease, 2 hypogonadism or prostate cancer receiving androgen deprivation therapy, and women with breast cancer receiving estradiol depletion therapy. I now look forward to the pre-recorded presentation. At the end of this presentation, we will revert to question and answer session.
Thank you for this introduction. I have no relevant disclosures. So in this talk, I will briefly cover the oncologic background to the topic, discuss the bone toxicity of endocrine therapy, outline benefits of anti-resorptive therapies, provide recommendations regarding assessment and management of these women, and end with summary and conclusions. So in terms of the oncologic background, in early estrogen receptor positive breast cancer, the more intense and of longer duration the estradiol depletion is, the better the oncologic outcomes, and so oncologists will treat high-risk women more intensively. In high-risk women, therefore, aromatase inhibitor therapy, which can be used as monotherapy in postmenopausal women, but of course must be combined with ovarian function suppression in premenopausal women is standard of care, and that leads to severe estradiol depletion with estradiol concentrations below that of natural menopause. Of note, women with early ER-positive breast cancer have a very low breast cancer-specific mortality, so the increased longevity in these women makes attention to side effects of endocrine therapy, such as on bone health, very important. Of note, there is literature that, especially in postmenopausal women, adjuvant bisphosphonates have oncologic benefits. So in some instances, oncologists will choose to treat high-risk women with these agents, which of course will cover bone health as well. So my subsequent discussion is pertinent to women who do not receive bisphosphonates for oncologic benefits. So what about the bone toxicity of endocrine therapy? And we summarized the literature some years ago, and the principle is that the more intense the estradiol depletion is, the more severe the bone loss. So tamoxifen, being a SERM, a partial estradiol receptor agonist at the bone, will modestly accelerate bone loss and increase fracture risk in premenopausal women, but has a weak protective effect on bone health in postmenopausal women. In postmenopausal women, aromatase inhibitor treatment accelerates bone loss by 2 to 4-fold compared to natural menopause, but it is really in the premenopausal women with severe estradiol depletion where bone loss increases markedly, up to almost 10% per year in premenopausal women that receive combination of ovarian function suppression and aromatase inhibitor therapy. Now, what about the toxicity of adjuvant endocrine therapy? And I first show you the data on postmenopausal women. So in earlier studies, aromatase inhibitors were compared to tamoxifen, and the evidence showed from this meta-analysis that compared to tamoxifen, aromatase inhibitor therapy increases fracture risk and causes fractures with a number needed to harm relative to tamoxifen of approximately 46. Of course, tamoxifen having a potential partial bone protective effect in these postmenopausal women, it is important to compare aromatase inhibitor therapy to placebo or no treatment, and this comes from extended aromatase inhibitor studies. And again, aromatase inhibitors also compared to placebo or no treatment increase fracture risk with the number needed to harm to cause one fracture, an estimated 72. However, in all these oncologic studies, fracture rates were not properly adjudicated, but instead collected as adverse event. And as you can see, the actual fracture reporting rates varied widely from 1 to 11%. And in these studies, some patients were treated with anti-resorptive therapy for oncologic benefits, all leading to a likely underestimation of true fracture risk with these agents. And this is borne out by the only dedicated primary bone outcome study in this field, which I'll discuss in a couple of slides. Similarly, in premenopausal women, again, with increasing intensity of estradiol depletion and increasing duration of therapy, fracture rates and osteoporosis rates increase markedly, reaching almost half of women being osteoporotic after treatment with ovarian function suppression and aromatase inhibitor therapy for 8 years. Given evidence that high-resolution peripheral quantitative CT is a technology that predicts fracture risk independent of DEXA and FRAX score, my PhD student, Dr. Ramchand, did a case control study and found that pre-menopausal women treated with ovarian function suppression and aromatase inhibitor therapy, shown here in the purple, have marked deterioration in their bone architecture, and their bone architecture, despite the fact that these women had received this treatment for a median of only less than 2 years, is markedly worse than that of pre-menopausal healthy age-matched controls, shown in the light green, but instead similar to the bone architecture of women who are at least 10 years post-natural menopause and about 20 years older, shown in the dark purple, suggesting that estradiol depletion in these women has, especially in these young premenopausal women, has marked concerns regarding their bone health. Now, what about benefits of anti-resorptive therapies? Regarding zoledronic acid, the best evidence comes from the Z-FAST study, where post-menopausal women who were treated with aromatase inhibition were either treated with zoledronic upfront or were given zoledronic acid only if their T-score during treatment declined to less than -2. And as it is evident, the immediate zoledronic acid group over the years maintained or even improved their bone mineral density, whereas women in the delayed zoledronic acid group lost bone with, at 5 years, a between group difference of approximately 10%. While this study was not powered for fracture endpoints, there is some evidence from the AZURE trial that showed that in postmenopausal women treated with aromatase inhibition, zoledronic acid given in an adjuvant setting, so slightly more frequent than we would give for osteoporotic therapy, was associated with a significant reduction of fracture risk, 3.9 versus 5.8%, although this again has limitation as outlined here, as the authors included traumatic and possibly pathologic fractures in some of these women with disease recurrence, and again fractures were collected as adverse events, probably leading to an underestimation of fracture risk. And this is really illustrated by the only study that was a dedicated primary fracture outcome study and the only study that was powered for fracture outcomes. And this study used denosumab treated in dosed in conventional osteoporotic terms, and recruited a large number of women, more than 3,000 postmenopausal women. And if you focus on the placebo group shown in the blue here first, what is striking that despite the fact that these women largely had normal baseline bone density, what is striking is that the fracture rates, clinical fracture rates in these placebo-treated women was 10% at 3 years and almost a quarter fractured at 84 months. And that fracture rate is similar to the fracture rates seen in placebo-treated women with established osteoporosis who were 5 to 10 years older. those recruited, for example, for the Horizon and Freedom RCTs. So illustrating the fact that the oncologic literature that I've just discussed before likely underestimated true fracture risk, and that aromatase inhibitors really have quite a marked toxicity at the bone. In this study, too, denosumab was highly effective at reducing fractures. It halved the absolute fracture risk at 3 months, so the number needed to treat to prevent from fracture of approximately 20, and this benefit was sustained over the longer therapy. And as you would expect, denosumab also increased bone mineral density. Of course, there's literature, and this was just an early study. Women with aromatase inhibitor therapy are not immune to the bone remodeling overshoot that occurs with denosumab, so obviously consolidation therapy needs to be factored in. And given preclinical data that accelerated bone remodeling in breast cancer women might increase skeletal metastases risk, there's also an added concern in these women of letting bone remodeling overshoot occur, because it might potentially accelerate their underlying cancer disease. With respect to pre-menopausal women, there's evidence that zoledronic acid prevents the accelerated bone loss that occurs in these women, and you can see again in the placebo-treated women with the most severe estradiol depletion, aromatase inhibitor therapy and placebo, the bone loss over 3 years was 13.6%, somewhat less as expected with the tamoxifen and ovarian function suppression combination. But those women who were treated with adjuvant zoledronic acid, again dosed 6 monthly at 4 milligram, zoledronic acid in this group prevented the bone loss that occurred completely. And what is also evident from this study is that once endocrine therapy treatment was ceased in the placebo-treated woman who did not receive zoledronic acid, there was some recovery of bone loss, although not back to baseline, probably due to the resumption of menses. So given denosumab is a more potent anti-resorptive than zoledronic acid, our PhD student, Dr. Ramchand, in collaboration with Peter Ebeling, did a study of denosumab in premenopausal women with estrogen receptor positive breast cancer. Women with a significant reduced low bone mass for age were excluded. Regarding baseline characteristics, women were about 44 years old. The majority had received chemotherapy, and their baseline bone mineral density in architecture was relatively normal. Now, in this study, denosumab, shown in red, was completely effective in abrogating the loss of areal bone mineral density measured by DEXA, and for convenience, we tabulated the data into percentage change. And again, what was remarkable, that in the placebo group, in the first year alone, lumbar spine bone loss with estradiol depletion was almost 10%, and part of this likely will be irreversible, so really begging the question whether these women should not be treated upfront with anti-resorptive therapy. And so denosumab was also effective in completely abrogating the bone microarchitectural decay as assessed by high-resolution peripheral quantitative CT, and in collaboration with Peter Ebeling's group, denosumab prevented the loss of bone stiffness and loss of bone failure load occurring with placebo, and these are validated predictors of fracture outcomes. given preclinical data that denosumab might affect glucose metabolism positively, we also looked at fat mass in these women and found, interestingly, that while placebo-treated women with estradiol depletion experience, as you would expect, a gain of regional and total fat mass, denosumab prevented this gain of fat mass, significantly so for android and gynoid fat mass, with trends for other regional and total fat mass and body weight and waist circumference in the same direction, suggesting that denosumab in these premenopausal women receiving estradiol depletion might have additional metabolic benefits, although further research is required. This shows a recent meta-analysis which summarizes more than 35,000 women with both pre- and postmenopausal breast cancer, early breast cancer, and reassuringly, although limitations of the studies are outlined and have been previously referred to below, reassuringly, it appears that compared to placebo, most bisphosphonates, with the exception of permitronate and denosumab, reduce fracture risk. So any treatment that you choose will probably have a benefit. What about assessment and management? And this is all published. We convened a position statement on behalf of the relevant Australian stakeholder societies, published in the Clinical Endocrinology Journal, and a summary statement in the Medical Journal of Australia. And this is all published, so in the interest of time, I won't belabor the fact, but obviously all women starting endocrine therapy, except postmenopausal women on tamoxifen, will need a comprehensive clinical and laboratory assessment of their bone health. And in terms of imaging, I want to highlight the importance of doing systematic thoracolumbar spine x-rays or vertebral fracture assessment, because we often find clinically silent pre-existing fragility fractures in these women, which of course changes the equation. In terms of management, anti-resorptive therapy should be considered for all women who meet general population guidelines, but on top of that, we felt that a T-score of less than -2 at any site, accelerated bone loss, or a elevated fracture risk should lead to anti-resorptive therapy, although arguably, based on the denosumab studies, both in post- and premenopausal women, treatment should probably be more aggressive. There's some controversy regarding FRAX and even whether ticking the secondary osteoporosis box fully accounts for aromatase inhibitor therapy. So another option would be to forego FRAX and consider treatment if 2 or more fracture risk factors. And so a similar guideline has been provided more recently by an international group, but essentially their recommendation pretty much align with us in that they recommend treatment in fairly similar terms. So, in summary and conclusion, I've shown you that endocrine therapy accelerates bone loss, except in postmenopausal women receiving tamoxifen, with premenopausal women receiving aromatase inhibitor therapy combined with ovarian suppression having the greatest bone loss. All women at risk of bone loss require a comprehensive assessment of their bone health. Women who do not receive anti-resorptives for oncologic benefits should receive anti-resorptive therapy according to these criteria, although given the denosumab studies as I outlined, treatment, especially in premenopausal women, should probably be more aggressive, and upfront anti-resorptive therapy in these women should be strongly considered. Overall, these recommendations largely stem from lower-level evidence and more dedicated outcome trials, ideally head-to-head comparisons, at least for bone density, and powered for fracture outcomes are needed in this population. For complex patients, and that's what we do at our center, where we run a multidisciplinary clinic together with our colleagues from medical oncology. Treatment decisions are often discussed in a multidisciplinary setting and should be individualized. So with this, I stop and I thank you for your attention.
So, Peter, it's now just you and me. Thank you very much in his absence today to Professor Grossmann for an also very good and comprehensive talk. So we have a few minutes remaining for the questions and answers. At this particular stage, we only really have one question, but I'll add some after that. So the first question is then obviously to Peter. Could you comment on the reasons or merits behind using T-score cutoffs for cancer-induced bone loss rather than FRAX-based cutoffs as per the ASCO and the UK NOG guidance? We did a local audit of this, and it does lead to this discrepant management in a significant minority of patients, about 20 to 30%. So I think that the question is quite clear. Why do we still base it on T-scores, or as in Professor Grossmann's talk, on a arbitrary cutoff level when using FRAX with the correction for secondary hospitals of a 3 and 20%, which has not really been proven in any studies. Peter, this is a complex question. I'm sure you'll answer it well.
Yeah, I think it's a difficult one. So if we're thinking about using FRAX universally, I'm not sure if Claire is from the United Kingdom, but as you know, FRAX is applicable to different countries if you use their own ethnicity-based fracture risk calculators. So that's probably an advantage of using FRAX. I think the T-score has been used out of convenience more than any other reason. You know, I know in our postmenopausal osteoporosis guidelines in Australia, we have categorization of fracture risk using FRAX in that rather than using, we can use a T-score as well. So I think you could have use both rather than just one. But yeah, 2 of the 3 guidelines I presented just used T-score, and I think it's more out of convenience rather than anything else. And I take the point that there will be discrepancies in the classification of patients if you use FRAX as opposed to the T-score. So Mathis was talking about using a T-score cutoff of -1, maybe in premenopausal women. And as you know, with our guideline, it was -1.5 with 2 clinical risk factors without the T-score. So our guideline gives the possibility of not using bone density. And I think that's important too, because a lot of countries, like in Kathmandu maybe, there is not access to bone densitometry. So we gave the possibility of just using clinical risk factors, but you could also apply FRAX using clinical risk factors alone and not incorporating bone density. So I think it's a good point, and we probably need more information to see what is the optimal strategy.
I quite agree with that, and would just like to add that the intervention threshold using FRAX is obviously not completely set, whether it is applicable to the normal intervention thresholds as used by the NOG group. And I'm pretty supportive of this FRAX and the intervention threshold model that they use. I think the other thing is that by just ticking on your FRAX model secondary causes as suggested at Wednesdays, I'm not quite sure whether that actually compensates for the increased risk that we get. So I think we need a little bit more information. And I'm not sure in FRAX Plus whether it actually makes provision for that, but in many other conditions, we have an arithmetical correction that we can use to do that. So maybe we should have a little bit more information on that before we want to apply it universally. Okay,
Agreed.
so I'm just going to add some very common questions. Um, the, uh, the two obvious groups of drugs to be used in the patient at risk is either a bisphosphonate or denosumab. Those are the two main ones. Could you perhaps describe to us some of the advantages to using a bisphosphonate in terms of oncological situation, in other words, anti-cancerous effects of the bisphosphonates, and if this is also applicable to our DMAP?
Yeah, well, I think that's a good thing to bring up. And there have been studies in breast cancer that shows that zoledronic acid actually confers a survival benefit or perhaps an anti-cancer effect, which is not seen with denosumab. Yet we have a lot of fracture reduction data with denosumab that we don't have as strongly with zoledronic acid. So it's balancing up those two things. And I think probably zoledronic acid is still a very good drug to use, although I think what we're seeing is denosumab is being used more frequently. And what we've been noticing actually is atypical femur fractures on patients with, say, metastatic breast cancer have been treated with denosumab at high doses for a long time. So that's something else to consider, because there's maybe not an end point for denosumab use. You may want to continue it rather than transition to a bisphosphonate. So I think these are all things to consider, and we're just learning, right? Because people have been using denosumab rather recently. So we've got a PhD student who's going to be looking at the data for denosumab use in cancer and the risk of atypical femur fractures at the moment. Yeah.
Peter, just also on a very practical note, if you decide to use DMAP, denosumab, just for the sake of fracture prevention in these patients, as explained, what would your length of therapy be, and what would you do when you get to whenever you think you should stop?
Yeah, so aromatase inhibitors tend to be used for longer than 5 years nowadays. So I would just use the denosumab for the duration of the aromatase inhibitor therapy. Now, by definition, that'll be longer than 5 years. Now, the recommendations, if you're going to transition somebody off denosumab after 5 years, is to use zoledronic acid. We would give zoledronic acid at the time of the missed denosumab dose, but then it's really important to get the patient back in 3 months' time and check the CTX level, because we know that some people will need 2 or more infusions to overcome that rebound increase in bone resorption. So we would get them back at 3 months and make sure the CTX is below 280. If it's not below 280, we'd then give another infusion of zoledronic acid. And then get the patients back in another 3 months. Now, I know one of my colleagues in Switzerland, Serge Ferrari, he's had a patient where they had to give more than 5 infusions of zoledronic acid to try and reduce this rebound bone resorption that occurs after cessation of long-term denosumab therapy. So it's something we're learning more about, but those are the ECTS guidelines for transitioning at the moment from denosumab to zoledronic acid.
More or less on the same trend, we have a question here about a patient who had been on zoledronic, who had been on a bisphosphonate for 10 years while using the AIs, or let's make it then 7 years, which is these days the maximum that you'd get. What would you do at the end of treatment? Would you stop it for how long? Could you just give us an answer to that?
Yeah, I think it's safe to stop the bisphosphonate whenever the aromatase inhibitor therapy stops. I guess there is a concern for having patients on 10 years of bisphosphonate therapy. It may be that you want to image the femur in those cases that are on longer for 8 years, or even consider stopping the bisphosphonate therapy after 7 or 8 years. If you've been giving zoledronic acid, there's likely to be a long sort of effect of the ongoing suppression of bone resorption for about 4 years, or 3 or 4 years. So you might even think of stopping the intravenous zoledronic acid after 6 or 7 years and just watching the CTX, I suppose, or the bone density. But yeah, so I think that is a concern for continuing bisphosphonates that long in patients on aromatase inhibitor therapy, because we know the risk of AFF goes up after about 8 years on therapy to about 130 cases per 1,000. Yeah.
Okay, Peter, just a very practical question again. The normal dosage of zoledronic acid as practiced in menopausal medicine is 5 milligrams of Zol, basically yearly for 3 years. But we find in the oncological articles that they use a different dosage, which is 4 milligrams, which and they use it every 6 months. Now, which is the correct dosage to use? 5 milligrams once a year or 4 milligrams 2 times a year?
I think 5 milligrams once a year would be adequate if you're preventing bone loss. So I think, as you know, in osteoporosis now, we're using it less frequently and using it every 18 months or so. And to prevent postmenopausal bone loss, as you know, there was a study earlier this year which gave it twice over 10 years, once every 5 years. And that actually reduced fractures in women who were about 60 years old. So I think, yeah, we're using it less frequently. So I think 5 milligrams every 12 months would be adequate. And that's what we've recommended in our guideline.
Would the same go for denosumab to stick to the normal dosage of 60 milligrams 6 monthly?
Yes, and that's recommended in the current guidelines. Yeah.
Sure. Just finally, a question about using these drugs for the prevention of metastatic bone disease.
Prevention of metastatic bone disease. Yeah, so I think there are limited data on that. We know that in people with established metastatic bone disease, it does these drugs at high doses prevent skeletal-related events, but I'm not sure of any data that actually show that it prevents the occurrence of metastases. But I think these drugs have transformed the survival of people with metastatic cancer. So it's really been impressive that it becomes more or less a chronic disease.
Thank you very much, Peter, for a lovely talk and very good and clear answers now. And also to Mathis, I'm sorry that he couldn't be with us. We missed him there. Thank you very much again to our sponsors. And we now have to terminate this session.